This is a submission for the Illinois Northern Chapter of the American College of Physicians poster competition. My name is Brandon Byers. I'm a fourth-year medical student from the American University of the Caribbean School of Medicine. Together with three Mount Sinai Hospital physicians, we present a case of a large left atrial myxoma that was detected incidentally in a patient prior to the period of COVID-19. The patient was a 48-year-old African-American man with no prior medical history. He presented to the emergency room complaining of worsening back pain and exertional dyspnea for the preceding 4 days. On the day of admission, he described 2 episodes of light hemoptysis earlier in the day. He explained that he has experienced chronic back pain for the last 4 months, but had previously attributed this to possible injury at his job. He denied recent illness, chest pain, weakness, fever, cough, abdominal pain, and lower extremity swelling. He was taking no medications and denied all allergies. He also denied any past history of tuberculosis, cancer, and deep vein thromboses. He's denied family history of cardiac conditions, clotting disorders, and cancers. He endorsed a 10-pack year smoking history, but denied all other substances and exposures. On exam, the patient was afebrile, setting at 100% on 2 liters, with a blood pressure of 118/82. He was tachycardic to 110 and tachypneic to 24. He was alert and oriented to person, place, time, and event. He appeared to be in no acute distress. Evaluation of the lungs revealed subjectively muffled right lung sounds. Cardiac auscultation revealed a largely benign exam. However, grade 2 mid-diastolic murmur was detected at the 5th intercostal space mid-clavicular line. Abdominal exams showed a non-distended, non-tender abdomen, and no lower extremity edema was appreciated. Initially, there was concern for a pulmonary embolism versus acute coronary syndrome and other respiratory infections, so a chest x-ray, EKG, cardiac markers, CBC, CMP, and blood cultures were ordered. Tentative results were all within reference ranges. His chest x-ray demonstrated a possible right lower lobe consolidation with hilar lymphadenopathy and right pleural effusion. Given the concern for pulmonary embolism, the patient also underwent pulmonary CT angiography. This imaging modality demonstrated an incidental left atrial mass with right hilar adenopathy and pneumonia. The patient was empirically treated for pneumonia and received urgent cardiac evaluation by cardiology and cardiothoracic surgery. A transthoracic echo showed probable myxoma with a 15.5 centimeter circumference and moderate increase in right ventricular peak pressure to 45 millimeters of mercury, but otherwise normal findings, including an ejection fraction of 55 to 60% and no regional wall motion abnormalities. The patient subsequently underwent transesophageal echo, which noted a freely mobile mass measuring 5.1 centimeters in length by 2.8 centimeters wide in the atrial cavity with an appearance consistent with myxoma. The patient underwent coronary angiography to establish no pre-existing coronary disease in advance of his cardiothoracic surgery. His coronary arteries were free and clear of atherosclerotic disease. The patient was consented and booked for surgery, which took place 2 days after his angiogram. The patient underwent median sternotomy with biatrial incision and excision of the left atrial mass. Subsequent pathology analysis confirmed the mass was, in fact, a cardiac myxoma. The patient remained in the SICU for 4 days. His course was complicated by an anticipated postoperative atrial fibrillation, which was successfully converted with amiodarone. He was discharged on postoperative day 4 and sent home on oral amiodarone and Eliquis. Cardiac myxoma, or CM, is the most common primary tumor of the heart with an overall incidence between 0.001% and 0.28%. More than 75% of them are found in the left atrium originating near the fossa ovalis, though some have been discovered on the roof of the left atrium and on mitral valve leaflets. Right atrial myxomas are less common, with an overall incidence of less than 18%, and ventricular myxomas are even less common. The finding of CM may be attributed to hereditary syndromes such as Carney complex. However, approximately 90% of CM are sporadic. Some research has suggested that a mutation resulting in overactivation of PKA and cyclic AMP signaling pathways may be responsible for both Carney complex and sporadic cases of CM, which may also explain the mucinous and myxoid stroma seen on biopsy. Symptoms are seen in 90% of patients and range depending on size and location of the CM. Left atrial CM often present with a variety of symptoms, including syncope, fatigue, dyspnea, palpitations, chest pain, and sudden cardiac death to the occlusion of the left atrial outflow tract. Peripheral embolization may also occur secondary to portions of the tumor breaking away. Very rarely do patients present with large myxoma and an absence of symptoms. And other research suggests that more than half of all asymptomatic patients may actually suffer from subclinical ischemic injuries to the heart or brain. All patients found with CM should undergo immediate resection, as the presence of such masses carries an 8% mortality risk. We'd like to thank Mount Sinai Hospital in Chicago, Illinois for their continued support, as well as the Illinois Northern Chapter of the American College of Physicians for their consideration of our poster and presentation.